we'll just see in a minute. As I said earlier, calcium must be always acid with albumin. When calcium values are in doubt, it is better to measure ionic calcium if you have a good quality ionic calcium with you. If you don't, forget it, because ionic calcium is even more difficult than serum calcium. So, if it is available, do it. In some disorders, especially when in hysterical patients, people presenting with carpal spasms but not showing serum calcium abnormalities, it might be worthwhile in testing a blood gas analysis during symptoms, because metabolic alkalosis tends to cause abnormal binding between calcium and albumin, and this reduces ionic calcium. So, actually more calcium binds to albumin, but symptoms come up because the ionic calcium drops precipitously. So, a severe metabolic alkalosis can cause tetany. You try it yourself, you breathe in and out rapidly for 50 times and you will start getting tingling in your around the mouth and tingling around your fingers, and that is typically because your ionic calcium drops. You can do it immediately, and the best way to treat it is what is simple. You just put a bag around your mouth and tell the patient to breathe in and out. You actually take away the metabolic alkalosis by breathing in and out, and that corrects the condition very simply. So, keep acid base disorders in mind, especially when interpreting calcium in acute critical care conditions or young girls presenting with so called tetany in casualties. They could be actually malingerers or they could show a hysterical conversion reaction. So, the main causes still remain three: hypoparathyroidism, chronic kidney diseases, and vitamin D deficiency or something called vitamin D resistance. Not very common, but certainly known. So, what about hypoparathyroidism? Now, when calcium reduces, as I said, PTH must go up. Therefore, a low or a normal PTH in the face of calcium indicates hypoparathyroidism. You don't necessarily need to have a low PTH to diagnose hypoparathyroidism. See, in endocrinology, everything is relative. So, if you have a calcium of 4 with a PTH of say 20, you will say it is in the normal range, because the range is 12 to 72 picograms per ml. No, it is inappropriately non-elevated. That is what the terminology is to be used. That the PTH should have actually been elevated if the calcium was 4. It is not going up. Why is it not going up? Because the parathyroid hormone is not functioning. This is called hypoparathyroidism, and typically you will have it along with a high phosphate. Now, high PTH in the setting of hypocalcemia, I told you sometimes people get high PTH values and they discard it. What does it indicate? It indicates secondary hyperparathyroidism. Basically what it means is that PTH is being secreted correctly. It should be secreted, but then it is not acting. Why is it not acting, and why is the calcium going low? Because there is a severe kidney disease, because 125 hydroxy D is not getting formed, or there is very severe vitamin deficiency, therefore the PTH is not acting, or there is a condition called pseudo hypoparathyroidism, which is a genetic disease. We can forget about that. But so one is a true reduction in PTH, primary hypopara. The second is a secondary hyperpara, which is not effective because of underlying vitamin D deficiency or chronic kidney disease. Now, magnesium is one more important factor, because magnesium is very important in the release and action of PTH. So, if you have hypomagnesemia, you will develop hypocalcemia, because the PTH responses to any kind of calcium flux are blunted. Therefore, as we were discussing, can I have 2 minutes extension, because this is just, so we were discussing that why don't all vitamin D low patients show actually a PTH elevation, and one of the reasons is magnesium deficiency, where PTH release can be hampered even though there is little bit of hypocalcemia. So, when the magnesium is low, low calcium may be associated with either low PTH or sometimes high PTH, but basically that is a state of PTH resistance. What about phosphate? Phosphate levels are to a large extent decided by 1, dietary content, and 2, urinary excretion. Dietary absorption is dependent on vitamin D and urinary excretion is dependent on PTH. So phosphate is a very important molecule if you want to understand why there is a low calcium or why there is an abnormality of calcium in the first place. So what typically will happen is, if you have low calcium and low phosphate, what does it mean? You are typically dealing with a vitamin D deficiency, because vitamin D absorbs both calcium and phosphate. If both are low, you are typically dealing with a vitamin D deficiency. But if a calcium is low and a phosphate is high, it is either hypoparathyroidism or it is chronic kidney disease. So these combinations, it's worthwhile remembering. Low calcium, low phosphate, first diagnosis vitamin D deficiency. Low calcium, high phosphate, either primary hypopara or CKD. And this again should be checked in the fasting state, because diet changes phosphate levels. This we have already gone through, and I am not going to check this, except this is, no, I am not going to do this at all. And the others which help are alkaline phosphatase. So typically, if you have a low calcium with a very high alkaline phosphatase, again you are dealing with a metabolic bone disease. Typically, most of the times it is osteomalacia, where you will find a high PTH and a very low vitamin D, or you will find it after surgery for parathyroid, where the bones are now hungry and they are picking up all the calcium that they had been starved of. So in this scenario, again alkaline phosphatase, which is again a marker of bone activity, will go up. In pancreatitis, which is another cause of calcium fluctuation, check amylase and lipase, and creatinine of course is very, very important.